Good morning. Welcome to Health Frontiers, Insights from the Experts, where we dive deep into the world of healthcare with some of the brilliant minds in the industry. I'm your host, Ankit Gaba, and today we have a very special guest with us, Dr. Manisha. Dr. Manisha is a professor in the Department of Medical Microbiology at PGIMER, Chandigarh. With immense years of experience in medicine, she brings a wealth of knowledge and groundbreaking perspectives to our discussion today. A very warm welcome to you.
Thank you.
So, coming on to the first question. Dr. Biswal, your work focuses on hospital-acquired infections, a critical area in healthcare in tertiary care settings. Can you discuss the challenges you've encountered in managing and preventing these infections and how your leadership has driven improvements in the hospital?
So hospital-acquired infections are it's a public health risk, and especially with antimicrobial resistance that we are seeing the world over, it's like a public health emergency. They say that more people are going to die out of antimicrobial resistant infection than any other infectious disease combined. So there are people all over the world now who are trying their level best to bring these infections down. And there are global action plans, then there are national action plans, and now in India we have started, six states have the state action plans, So it's an emergency now to bring down AMR and hospital-acquired infections due to AMR. PGI has been at the forefront for many years now. People before me and then with everybody else, the team, with our leadership in PGI, we have been very pro in this field, trying to reduce hospital-acquired infections. One common problem I think today also we discussed is the lack of finances, resources that are given to for the prevention of these infections. But being in a low middle income country, it is a constant challenge, partly because of this and partly of the other issues which we handle every day. So it's a constant challenge, but that's it. That's with leadership and a lot of political will, we have managed to go someplace, but we still have a long way to go as far as prevention of these infections are concerned.
That's very reassuring to hear that we are having such a proactive leadership and people like you leading the hospital-acquired infection field. As a member of international and national professional bodies like the International Federation of Infection Control and the Hospital Infection Society of India, how do these affiliations enhance your approach to infection control in the hospitals?
Yes, so talking to people all over the world today also, they're all from other countries. That's very it teaches you many things. So what you are struggling with in your own hospital is maybe you've been trying to get a solution for that, but talking to people the world over and in other settings will give you solutions that other people are implementing, and sometimes that is very reassuring. The other reassuring thing is that you know that you're not alone in this fight, and everybody else is also going through the same problems that you have to face every day. So our infection control nurses, there's similar doubts, same things. Many people will ask, other workshops that we've conducted all over India. Very few hospitals are privileged to have everything that they ask for as far as prevention of infection is concerned. In a public sector hospital like PGI, it is very reassuring to know that there are, solutions that people are trying which do not cost a lot of money but which are effective. So these federations, these infection control bodies, they work towards having solutions like this. So networking is very important.
Following up on that, how do you integrate global best practices into your work at PGIMER?
To a large extent, we do. We have leadership which is very pro. Our medical superintendent has been part of our infection control committee for a long time, and all the directors who I have worked under are also very extremely concerned about hospital acquired infections, and they know that it is in the best interest to reduce hospital acquired infections. So whatever global practices are, and then we raise the same recommendations with them and through our committees to them. They try their level best to implement it. So there is light at the end of the tunnel. The tunnel is very long right now.
Indeed, ma'am, and we are proud of the work that PGI has been doing so far, and we always look up to for guidance to the work. Coming on to the next question, your expertise in scrub typhus and rickettsial diseases is quite specialized. What drew you to these areas, and how do they intersect with your broader work in hospital-acquired infections?
The scrub typhus is classically it was thought to be in the one region of the world and only in the hilly areas, etc., etc. But since 2012, we found that a lot of people who were in the plains, who do not have any contact of going up do not have any history of going up to the hills and all, they're also coming down with fever, and they're negative for the usual causes of fever. So then these diagnostics were introduced in PGI, and we found that a lot of patients have scrub typhus and these other infections. So they are a little difficult to work on because they're not culturable, these pathogens, they're not like Staph aureus or Klebsiella that can be cultured. So the diagnosis is a little indirect. So, but since we have started diagnostics, we find so many patients with them. So now it is established, and PGI is now part of this national network where we are trying to do capacity development in local medical colleges. PGI, we get patients from some 7 or 8 states just because it is tertiary care. So patients cannot, if the fever goes on for some time and it's not being diagnosed in any of these hospitals, they'll come to PGI. There's a lot of overcrowding in PGI because of that. So what we now want to do is also for infection control is develop, capacity in all the hospitals around so that their patients are treated there itself. It is easy to diagnose scrub typhus. There's one ELISA, there is one PCR. And there is a fantastic drug for scrub typhus, doxycycline. So patients who have scrub typhus, 1 or 2 days, they will become afebrile. There is no drug resistance so far to the organism. And that's a good thing. So if we are these people are able to diagnose there, then the patients get treated there. There's no need for them to come to PGI and create. Actually, they're interrelated, So we have more scrub typhus patients, more overcrowding, and more hospital-acquired infection. So, it kind of like in our best interest only, PGI's best interest only to help other hospitals so that they are treated at the local level only.
Indeed, ma'am. I hope we soon develop that capacity so that they are treated at the local level and we can focus on other more difficult cases at PGI, which also helps reduce the burden.
Yes.
Moving forward, as a professor at PGI, you're not only leading research but also shaping the next generation of microbiologists. How do you balance these roles, and what strategies do you employ to inspire and guide your students towards excellence in medical microbiology?
So for that, we have excellent role models. We have all been trained by the absolute, leaders, global leaders in microbiology. So we have had fantastic teachers, Dr. Arunalok Chakrabarti, Dr. Pallabre. So these are people who are known all over the world because of their work, and we have learnt from them. And one thing they've always encouraged is for us to go from in microbiology. Microbiologists are supposed to be in lab. So basically we do bench work, reporting in lab, samples come to us and we don't see the patient. But one, because I work in hospital infection, so we have rounds in hospital and we actually get to see the patients. For the other infections also, it is important, this message to the microbiologists is for them to go out into the hospital, see patients, see the conditions under which patients are being treated, and actually work on the problems at that level. So apart from the bench work, So this is something that has been taught to us by our teachers, and that is what we continue to do in PGI, is to tell the students to uh, not just do bench microbiology, but to also do bedside microbiology. So that that comes with the, that's how microbiologists are trained in PGI.
That is indeed a very good practice. I remember I had myself gone to an institute where they used to have rounds of infectious disease and internal medicine residents with the microbiology team, so they could like clinically and microbiologically correlate and come up to a better diagnostic and treatment for like the patient and overall growth of both the teams.
That is essential. Today also in the cases we discussed, no, one important thing is communication. So basically, most of the participants here are nurses. So they're the central portion in the hospital, but then there are many people that they have to communicate with. So unless you have a team and you build that team over time, then it is impossible for only one stakeholder to work or to bring about any change. The microbiologist has to be involved, the nursing people, they're the core, of course they have to be involved, but the administration has to be involved, the doctors have to be involved. You have to talk to a lot of people day in and day out, so that things are in place. So that is something which is core to hospital-acquired infection and many healthcare settings. No?
Yes, ma'am. And coming on to the last question, what are the opportunities for nursing leaders in teaching research and administration?
Oh, huge. I have been advocating nursing leadership since a long time, because I work very closely with infection control nurses. We have 3 infection control nurses right now. We have 2,500 beds, and the recommended ratio for bed to infection control nurses is 1:80. They say now in acute care hospitals you need to have 1 infection control nurse for 80 beds. First, initially they used to say 100 to 250 beds. So I have been pushing for more infection control nurses, and the ones that we have been working with me for years now. And the immense amount of experience that they bring to this field it's incomparable. And the work they do, because infection control nurse is a nurse after all, and she will be communicating with all the people who's working in the hospital. So the kind of clout they have, the kind of experience that they have, I have witnessed that myself. So I know that it's their leadership which actually brings about change, nobody else. We can only stand on the side and say advice, okay, technically this is right, this is wrong. But somebody on the field is the nurse. There is a very beautiful article in Clinical Infectious Diseases. I will share that also. Nurse as the AMSP champion, antimicrobial stewardship champion, and there is a table in that. So where they, for the nurse, all the activities that are done are ticked. So for a doctor, maybe 3 or 4, hospital administration 3 or 4, But for the nurse, it's ticked for everything. But she's there everywhere. If she's there everywhere, then she is the right person to lead. So the nursing leadership, without nursing leadership, so many implementations fail. It happens, the Big Bang, something is introduced, etc., etc. But if the champion of the ward is the nurse, she does not take it forward, then that thing will not be implemented. So I think not just in infection control, in many things now, nursing leadership is being touted as the next. It has to be done, otherwise it's simply not going to work.
Definitely, ma'am. And we are proud to have so many brilliant nursing leaders among us in the audience today. So coming on to the end, thank you so much for sharing your insights and experiences with us today. Your journey and advice are truly inspiring, ma'am. Thank you so much.
Thank you.
Stay tuned for more episodes featuring trailblazers from various fields. Until next time, keep pushing the boundaries and leading with impact. Thank you.